The gallbladder is usually found tucked under the liver. To obtain the best image of the gallbladder, examine the patient in the supine and decubitus positions. A normal gallbladder is quite variable in size and looks like a black hole with fluid inside it and a thin white line around it. Abnormalities found within the gallbladder include sludge, stones, polyp, or tumor. In the right clinical scenario, the presence of fluid around the gallbladder with a thickened wall may suggest acute cholecystitis, but it is important to elicit tenderness over the gallbladder as well. Many images that claim to show sludge are actually showing artifacts. Sludge is thick and moves slowly, trickling down the gallbladder. Unlike kidney stones, gallbladder stones move. They appear as white masses with a shadow, and sometimes it is necessary to use a higher frequency transducer to demonstrate the shadow. By moving the patient's body, you can identify stones within the gallbladder with 100% confidence when you see them move. The normal common bile duct, a tiny tube coming out of the porta hepatis, increases by 1 millimeter per decade starting at about age 40. Before age 40, a normal common bile duct is 4 millimeters or less. Around age 60, that number jumps to 6 millimeters or less. And by age 80, it rises to 8 millimeters or less. Abnormalities of the bile duct include dilation, choledocholithiasis, and tumor. The most common problem found in the bile duct is dilation, or an enlarged duct due to blockage. Simply by measuring the common bile duct, you can determine if dilation is present. In some cases, you can also identify choledocholithiasis, or stones in the common bile duct. These are sometimes hidden behind structures like the gut. The normal pancreas is white, echogenic. The splenic vein is the key to its identification.
Okay, we came down a bit further and saw the pancreas. Beautiful, nice shot of the pancreas there.
The neck of the pancreas lies anterior to the junction of the splenic vein with the superior mesenteric vein, forming the portal vein. Anterior to the splenic vein lies the body and tail of the pancreas. The head lies to the right of the portal vein, anterior to the inferior vena cava. A basic AIUM splenic exam involves adequate images of the spleen. To get the best image of the spleen, tip your patient left side up and scan around the lower costal spaces until you find it above the left kidney.
So this is the left side, and we can see the spleen. You want me to use the arrow? Yeah. You see the... Okay, breathe in. You can see the spleen here. You can see that the left hemidiaphragm is moving. Breathe in and out. Okay, good. It's the hilum of the spleen here, and it's just a nice normal texture. There's no focal masses. Focal masses of the spleen are not uncommon. Hemangioma is the commonest mass that one comes across.
Abnormalities found in the spleen include splenomegaly. An enlarged spleen or splenomegaly is very common. You can identify it by measuring the size of the spleen. Any spleen over 12 centimeters is too big. It is commonly seen in glandular fever, portal hypertension, lymphomas, and leukemias, as well as numerous other causes. The basic AIUM abdominal aortic exam is one that measures the diameter of the entire abdominal aorta, notes the presence and size of any enlargement, and documents the relation of any aneurysm in relation to the renal arteries. To obtain the best image of the aorta, try to look at the entire abdominal aorta from the level of the diaphragm to the level of the umbilicus, where it bifurcates into the two common iliac arteries. In obese patients, this may be quite difficult. You may have to press quite hard and try scanning more on the right side of the body. A normal abdominal aorta looks like a straight tube with a black hole in the middle. It is usually about 2 centimeters in diameter. We do not talk about an aneurysm until the diameter is 3 centimeters or greater.
This is a left parasagittal scan. You can see the aorta quite nicely here in its longitudinal extent. And this is the upper aorta. Most aneurysms, 85% of them are infrarenal. We can see a couple of branches off the aorta here. First of all, there's a celiac branch coming off here, and a little bit lower down here is a superior mesenteric artery coming off here. This level. And if we wanted to measure the aorta, it's important we measure the walls as well. And we measure it superiorly, we measure it in the middle, and we measure it towards the bifurcation, and this is usually where the aneurysms occur. So that as we get down, we're running into a little gas, so I'm pressing quite hard now. And I'm going to freeze this. Really pressing quite hard. And we're going to measure with the walls, and it is about 200. Now that's about a normal aorta. Now as we get older, we often become ectatic, and so we don't talk about aneurysms until it gets up to 3 centimeters. Aneurysms tend to get bigger with age. In fact, I'm just getting down a little bit further, and this is really a bifurcation down here. So we talk about aneurysms. If they're bigger than 5, then they're in imminent risk of rupture, and we talk about doing surgery on them. So here is really the level of the bifurcation. We can include the wall here very nicely, and you can see the maximum is less than 2 centimeters, which is really what most people's aortas are, really less than 2.
As in this case, abdominal aortic aneurysms may have sessile thrombus. Free fluid appears as a black space that you see between the liver and right kidney, around the spleen, and down in the pelvis. Free fluid is most likely found in what is called Morrison's pouch, between the liver and the right kidney.
Morrison's pouch. If you remember your anatomy, the peritoneum has connections which dictate the position of fluid, and the peritoneum comes around the surface of the liver here, and it comes down into this hepatorenal pouch here, and the peritoneum goes right the way down to the anterior surface of the adrenal before it's reflected back. So in between these 2 layers of the peritoneum is a potential space, and in the supine position, which patients who have just had a bad accident happen to be, this is the lowest part of the peritoneal cavity, and therefore fluid will be seen in this hepatorenal pouch of Morrison's pouch. To a lesser extent, there may be fluid in the left side of the abdomen. In the emergency room now, they are looking in the 4 quadrants as a possible way of looking for fluid collections, such as blood. You may see it around the spleen here, because again there is a peritoneum between the spleen and the left hemidiaphragm. You also look at the 2 lower quadrants and the pouch of Douglas in females for that fluid as well, because the lowest part of the pelvis is in the pouch of Douglas.
It is possible to detect free fluid in the pleural space as black spaces superior to the diaphragm. Another very important subject is artifacts.
This really is really applied physics in a way, but it's a very important cause of false positive diagnoses. If you don't recognize them for what they are.
There are three basic assumptions made in ultrasound imaging. 1. Sound travels in a straight line. But sound may be reflected or refracted at interfaces, and this change in direction is not present on the image, leading to artifacts. 2. The ultrasound beam is infinitely thin. This is not true ever. The beam has varying width, which makes thin structures appear thicker. 3. All echoes arise from structures in the center of the beam. In fact, there are side lobes which produce artifactual sludge in cystic structures, such as the gallbladder, and other artifactual lines from adjacent bone or gas in the gut. Some artifacts are useful. For example, the enhanced echoes behind a cyst and refraction at the edge of a cyst aids in recognition. A full treatment of this subject would require a separate tape. To recap, the basic abdominal examination consists of basic renal, hepatic, splenic, and abdominal aortic examinations and a search for free fluid. The renal exam investigates the kidneys to make sure they are free of obstructions, cysts, stones, and tumors. The hepatic exam investigates the liver, gallbladder, common bile duct, and pancreas. The liver is checked for size, position, and masses. The gallbladder is examined to see if the wall is thin and free of sludge, stones, and tumors. The common bile duct is scanned to see if it is enlarged. The pancreas is viewed for masses and size of the duct. The splenic exam involves measuring the spleen to make sure it is not enlarged. The abdominal aortic exam measures the diameter of the entire abdominal aorta from the level of the diaphragm to the level of the umbilicus to rule out an aneurysm. And the basic abdominal exam also includes investigating several areas of the abdomen for the presence of free fluid.
Well, overall it's very effective. I think if it's being done by people with experience, and particularly experience with interpretation, I think it's very effective, as I say, providing immediate, first imaging technique which may produce the complete answer. If not, at least it tells you. We can then suggest what should be done next in the way of a diagnostic imaging test or modality or biopsy or whatever. Well, again, it's stress may be too much, but this is a pleasant examination for the patient. You don't have to have a lot of preparation. It is painless. It can be done in very sick patients, and you can't take very sick patients down to have a CT or MR. I mean, that's a nightmare. The MR with an inability to have any ferromagnetic metal, for example. So this can go just straight to the bedside. We can guide procedures at the bedside. We can drain abscesses at the bedside. There's no modality that really competes with the portability of ultrasound, the ease of it, and have all those advantages and the accuracy of it.